Hey guys, so this is our review for colorectal cancer, and I'm actually going to do this one in two parts because it is such a long section in our book, and it's a whole lot of information. So it's actually one of the longest sections, I think. It is starts on page 1126 of chapter 56. And this is going to include cancer of the colon and rectum. And it's one of the most common cancers, but it's highly curable if it's caught early. Most are adenocarcinomas, and they come from polyps, basically. So they can metastasize by several different methods: direct extension, blood, or lymph. Direct extension is going to be when they metastasize to nearby organs. So most common one is going to be the liver. Our risk factors for these patients is basically, there's a pretty long list, but if they're over the age of 50, if they have a genetic predisposition, if they have familial adenomatous polyposis and FAP. We're going to call it FAP because that's what the book calls it. And then Crohn's disease, ulcerative colitis, people with a first-degree relative, and they are 3 to 4 times at higher risk for colorectal cancer. Also, if they are a long-term smoker, obese, if they have a sedentary lifestyle, if they take in high amounts of alcohol, and then also if they have a diet that is high in animal protein. So it's a high-fat diet. And then diets that are low in complex carbohydrates and fiber. Basically, if they're eating the standard American diet, they're going to be at risk. So for health promotion, we would like to suggest genetic testing for patients with a family history of FAP and Lynch syndrome, which is basically Lynch syndrome is a genetic predisposition to colon cancer. So also, we want to recommend that they have diagnostic screening, start discussing it with their doctor at the age of 40. And then if they don't have a family history or any risk factors, then they can wait until they're 50 years old to start their screening. But if they do have a family history, then they will probably start their screening process closer to the age of 40. There is a chart, 56-4, and that tells us the recommendations for screenings. The fecal occult blood test they should have every year, colonoscopy every 10 years, or a double contrast barium enema every 5 years. And then they should be screened more often or earlier if they're at higher risk. If they want to be, preventative about the whole thing, then they should decrease the fat in their diet, specifically animal fat, and then refined carbs and low fiber foods. So basically, they need to eat more produce and exercise. As far as the assessment part, we want to ask them about risk factors. So if they have had any previous cancers, and then also if they have ulcerative colitis, Crohn's disease, history of polyps, or a family history. Also, if they've got had any vomiting or changes in bowel habits. The shape of their stool is important. One of the classic signs of colon cancer is ribbon-like stools, and then also abdominal fullness or pain, any unintentional weight loss or fatigue too. So as far as signs and symptoms, so that will actually depend on the location of the tumor. And I'm not going to get super detailed on that because there's just that's a lot. So we'll go with the most common symptoms just in general. Rectal bleeding, anemia, and changes in stool shape and consistency. And then hematochezia is the passage of red blood via the rectum. So if you see that word, that's what that means. Occult red or tarry stools, and then gas, pains, and cramping. When we do our assessment, of course, we want to inspect first. So you're going to look for a distension or any visible masses. And then when you auscultate, you're going to listen for high-pitched tinkling sounds. That's usually a partial obstruction. And then no sound is a complete obstruction, which I guess is why we have to do 5 minutes in each quadrant. With palpation and percussion, that's going to be performed by an advanced practice nurse or physician. So not something that we should be doing. Also, they can have a digital rectal exam to feel for any tumors. Now, if the patient has that, then we cannot do occult blood testing on them because obviously the digital rectal exam can cause bleeding. So if you're going to do the testing, it has to be done prior to. As far as labs, we are going to look for a decrease in hematocrit and hemoglobin. And then also, if it's metastasized to the liver, then they're going to have elevated liver enzymes. And then as far as the fecal occult blood test, it's really common apparently for false positives because patients should stop eating red meat, taking aspirin, vitamin C, iron, NSAIDs, or corticosteroids 48 hours before the specimen collection. And then we also need 2 to 3 stools on consecutive days, and that's how we're going to test for that. Another lab value we can look at is the carcinoembryonic antigen, or CEA. That is going to be elevated pretty much all the time for smokers, but normal value is less than 5 nanograms per milliliter. If that shows up on a question. Now, we want to do imaging, so the double contrast barium enema can be done. Also, CT or MRI. Colonoscopy is the gold standard for colorectal cancer, so they can also have a sigmoidoscopy, and then generally during the colonoscopy or sigmoidoscopy, we can get tissue samples for biopsy. So with surgical intervention, we want to remove the tumor or as much as possible. And patient can have adjuvant therapy as well. So that's going to be your chemo and radiation. They're always going to have radiation if it's rectal cancer. And then if the radiation, basically what radiation does is it's going to stop the cancer from advancing, from growing. So it just really is there for regional or local control of of the disease. So it's going to pretty much be palliative. But if they're stage 2 or 3, then they're going to do chemo. So the 5 fluorouracil, and then the the leucovorin are the 2 drugs that are mainly mentioned. But really, we want to teach the patient the side effects of chemo and radiation. So, diarrhea, mucositis, leukopenia, mouth ulcers, and then peripheral neuropathy. So we should teach them about that. We need to talk about antiemetics and also opioid analgesics as well. For these patients, sometimes can also have vascular endothelial growth factor receptor inhibitors, and those block the cancer cell growth factors. So if we catch it really early, they can be given that. So just remember, growth factor. We want to stop those cells from growing. And then for surgical management, the surgery is really going to depend on several factors. So the doctor is going to look at the size, the location, the extent of metastasis, bowel integrity, and then the condition of the patient. And that's going to determine which surgery they do. So regional lymph nodes are actually usually removed as well, so that they can be tested for cancer cells, and then depending on the results of that helps us give the patient a more accurate prognosis. So I also have chart 56-1 and 56-2 highlighted. So those are going to be so many notes, guys. So many notes. So 56-1 is going to be the chart that's on, sorry. I think I have the wrong chart written down because that was for obstructions. Just look in the book. Okay, so chart table 56-1. Sorry, shouldn't be chart, should be table 56-1. That is basically going to give you the surgical procedures for colorectal cancers in the various locations. So it goes through right-sided colon tumors, left-sided colon tumors, sigmoid tumors, and then rectal tumors. I'm not going to go through all that because there's a lot there, so just take a peek at that. And then 56-2 is the pre-op assessment before ostomy surgery. So, and then we've also got figure 56-4, and that actually shows you the locations of the ostomies, so, or the stomas. So just kind of check that out. But that is going to be done by an advanced practice nurse or wound care nurse specialist too. So for the surgery, they can do a colon resection, usually done laparoscopically for increased healing time and less pain. Also, they can do a colectomy where they just remove the whole colon, and then an abdominoperineal resection, so something more invasive, but they may or may not keep their colostomy, just depending on where the surgical site is. So it will really depend on that. As far as pre-op instructions, We want to reinforce what the physician has already explained to the patient. And then we want to tell them there's a possibility of having a colostomy. So just depending on a lot of factors, I want to kind of mentally just prepare them for that. And then also for these patients, we want to teach them about incision care or wound care. And then if they have lower rectal surgery, then we want to tell them ahead of time that they are going to be at risk for a post-op sexual dysfunction and then urinary incontinence. Those are the two things that said to kind of go ahead and discuss with them. And then obviously they're going to be under anesthesia, so we need to make sure that they're using their spirometer and keep an eye on respiratory. They also may do a bowel prep, just depending on the surgeon's preferences. Will depend on which bowel prep they do. So for these patients, they also can have a nasogastric tube decompression after the surgery, and then for minimally invasive surgical patients, so if it's laparoscopic and it's not super invasive, then they may not have an NG tube. Just heads up on that. And then also we need to teach them about the patient-controlled analgesic, the pump. And then I'm actually going to stop there and do a second video for this one. And we'll go over the post-op instructions and then also their home care and recurrence rate, all that stuff. So I hope you guys are doing awesome, and I will continue the videos shortly. Thanks. Bye.